Now, the topic actually which is given to me is HMA in high risk myelodysplastic syndrome and the potential role of oral azacitidine. So this talk actually I would discuss in three components. The first is the high risk myelodysplastic syndrome. Now, the previous speaker, Austin, has made my talk a little bit easier because he has already discussed about what is low risk. So the two classifications which are used is one is the IPSS given in 1997, where you have these parameters. And generally, you consider the score when it is intermediate 2 or high as high risk MDS. And the revised ISS, which was given in 2012. And here you have, the 5 categories. And as in the previous talk, Austin has said very low, low and intermediate comes in the low risk, and high and very risk comes in the high risk myelodysplastic syndrome. And what is our worry in high risk myelodysplastic syndrome? Their median overall survival is actually less than 1.6 years. So a very high risk has only 0.8, that means 8 months, and a high risk has 1.6 years, which basically means that even if you are treating these patients, if you are not altering their natural history, these patients are not going to survive. So that means whatever treatment which you want to give, you want to alter the natural history of their disease. So what is the treatment of the high risk patients? So you divide these patients whether they are transplant eligible or they are transplant ineligible. The reason for that is if they are transplant eligible, your aim is for a cure, which you are not sure whether they will get a cure or not, but your aim is a cure. Whereas in patients who are transplant ineligible, your aim is to get the PFS benefit as well as quality of life benefit. Now, what are the problems? What are the issues when you talk about transplant in these patients? The issues are these patients mostly are elderly. In the West, in the Indian setup, obviously their age is little lower than what you see in the West. Many of these patients have comorbidities. Then sometimes there is a problem of availability of match, even though these days we have haplodonors now. In spite of that, when you are taking up these patients for transplant, there is high mortality and only 30 to 40% potential cure. And this is because of the different reasons, iron overload and transfusion requirement and many other things. And hence these patients, many times you give a bridging therapy with hypomethylating agents. Now, one of the paper which is looking at whether these patients who have a borderline blast percentage between 10 to 15% or 18%, whether you really need to give them bridging therapy with the HMAs or directly take up these patients for transplant. This is a one retrospective study. There is no prospective study on that. This is one retrospective study from, I think, Korea, looking at that if you are able to achieve a CR or some remission in these patients do better. So a complete remission, marrow complete remission with or without hematological improvement, that showed significantly better 4-year disease-free survival as compared to patients who did not have a response in the bone marrow. So meaning thereby that even though it's a retrospective study, but probably those patients who have a borderline blast percentage, it is better to give them bridging therapy with hypomethylating agents. Now, the second group of patients are those who are transplant ineligible, where you want to have a PFS benefit and quality of life benefit. And the only drugs which we have for them is azacitidine and decitabine. So this was, so in my talk, there are 3 components. One is high-risk myelodysplastic syndrome, which I have discussed. The second component is what are the HMAs, And as I discussed in the previous slide, azacitidine and decitabine. Now, what are these hypomethylating agents? Basically, there is a lot of methylation which is happening, and this figure actually shows the duplication, the replication which is happening. And once you give the hypomethylating agents, they act on these. I'm not able to. Okay, this is the pointer. So they act on this, or they go there, and they lead to the reactivation of previously silenced genes, leading to some improvement in the marrow. So even though these azacitidine and decitabine were made in 1964, so it is long back these two drugs were made, but and initially they were made as a cytotoxic agents, but it was not until 2000 when these drugs were found to be useful, when they were using in a low dose kind of a dose in these patients, and they were found to be useful. So this is one of the first trial which looked at the randomized control trial of azacitidine in patients with MDS. This was a CAL-GB group looking at 191 patient, where they gave azac 75 milligram per meter square, a standard dose subcutaneously for 7 days, and compared with the supportive care. The supportive care is just to give transfusion or low dose azac. And the overall response occurred in 60% of patients. Complete responses were very low, 7%, 16% partial response, and 37% just improvement in the transfusion requirement, versus 5% improvement with the supportive care. So obviously this was quite significant, and was approved for MDS, and this was one of the first drug which was approved for the use of MDS in 2004. This was the looking at the overall survival with AZA or supportive care. Then there was a phase 3 trial which also looked at the same thing. This was an international multicentric trial, and the median overall survival was 24 months versus 15 months in AZA versus supportive care arm. So basically, these studies suggested that AZA increases the overall survival of patients with high risk MDS. And there are various other trials, and these CAL-GB trials were 8421, 8921, and 9221. So in all these trials, it was seen that the complete remission rates were varying from 10 to 17%, even though the overall improvement happens in almost 40 to 50% of patients. And these responses start happening after the second or third cycle, and 90% of responses are seen by cycle 6. Along with azacitidine, there was also a use of decitabine, and this is one of the randomized study looking at the 3 schedule of low dose decitabine in high risk MDS. And very interesting, it was given as IV 5 days. It was also given as subcutaneous. Now we generally give decitabine as IV only, but this can be given subcutaneous also. So even though this route is not as such got very much attention, and so and the third group was where it was used as 10 days. So 5 days IV, 5 days subcutaneous, and 10 days IV. And it was found to be useful when it was given as 5-day schedule, and IV became popular. Again, this was a multicentric randomized trial which was published in 2012. So generally, the dose which is used for decitabine is 20 milligram per meter square as 1 hour infusion for 5 days. So in this trial, it showed the increase in the overall survival approximately 2 months, even though this trial did not met the primary endpoint, but on secondary analysis, there was a significant difference. So even though decitabine is approved in USA, it is not approved in Europe. So after so many studies, this is a systematic review of clinical trials. And again, this shows the pooled marrow CR rates are approximately 9 to 10%, the CR rates 17%, and the overall survival, which is year and a half when you use these drugs in high risk MDS. Now, the third component of my talk is looking at the potential role of oral azacitidine, which is the most difficult part of it, because oral aza is actually not approved for MDS. You know all that. So what I would do is that since the topic is the potential role, so I would discuss how an oral aza had come into the practice in the clinical practice. So obviously when you are using IV, patient has to come every month to the hospital, get his test done. There is pain. There are so many issues when the patients are on IV therapy or even subcutaneous therapy. So that's why there was a need which was felt to develop oral agents, because of the potential offer a convenient alternative to injectable hypomethylating agents. However, the current FDA approved indications are narrow, and unless you show the efficacy of oral AZA in the clinical trials, only then probably you can use them. So what's the need? All these patients who respond to hypomethylating agents, generally you have to continue as indefinite therapy unless you take up for definite therapy in the form of a transplant. The IV infusion or even subcutaneous infusions are uncomfortable, pain and swelling and so many other issues. And, you know, having monthly visits to hospital, because most of these therapies are given every 4 to 6 weekly. The other thing was that even though these drugs are are getting used in patients with the high risk MDS, but the kind of results which you want to see in these patients are you are not able to see them. So even in clinical trials, generally the results are better, but in the real world you are not able to see. And one of the reason maybe that many patients are either not getting this therapy because if the patient is from a faraway place, he may not be coming to the hospital to get this form of therapy. So there is underutilization and poor persistence with HMA therapy, and that's why there is a suboptimal outcome in these patients, and thus highlighting the need to improve utilization and persistent. And one is you make an oral form of the drug. And there are studies, people have looked at the patients of MDS who are on injectable hypomethylating agents. What are their perspective? And this is a study which is published just last month. Obviously this was a questionnaire based study, so of patients with MDS who are on HMA. So patient experienced pain, discomfort, interference with daily and social activities, and productivity loss. So hence there is a preference for an oral form of therapy if it is available. Now, the oral form of oral azacitidine was actually made in 2008. So 2004, it got the IV and subcutaneous approval. 2006, the decitabine got the approval. The oral form was made in 2008, and this is the first formulation which was supplied as 20 milligram film coated tablet. And at that time, this pharmaceutical company was different. Later, it was bought by Celgene. So it was given as 80 milligram dose, and the mean bioavailability was 17.4%. So that means even if you are using 80 milligram of oral azacitidine, now currently, if you remember, the dose is 300 milligram, and the bioavailability still remains the same. I tried to search the literature why 80 milligram of tablet has been discontinued and why we have moved to 300. I did not get the answer. Maybe we have to write to Garcia Monroe in MD Anderson that if 80 milligram of tablet is making the same bioavailability as 300 milligram, why we are using 300 milligram of tablet. Anyway, so later on, so this was a phase 0 kind of a trial where they just wanted to look at giving the drug. I wanted to look at whether there is some hypomethylation which is happening in the body or not. The phase 1 was published in 2011. So here they gave first cycle of subcutaneous azacitidine, followed by oral azacitidine. The dose was varying from 120 to 600 milligram for the first 7 days only. So it was So 7 days subcutaneous, 7-day IV, and the oral one was also given up to 7 days. The MTD was 480 milligrams. At 600, there was a grade 3 to grade 4 diarrhea. So the dose which was selected was 480 milligram, and the mean oral bioavailability ranged from 6.3 to 20%. Again, as the same as with 80 milligram. Then, it was looked at how do we increase the hypomethylation of with oral. So the short plasma half-life of azacitidine, the S-phase restricted incorporation into DNA, and rapid remethylation of DNA were the contributing factors to the importance of chronic exposure of the drug. And then at that time, it was felt that if probably instead of 7 days, if you give for 14 days or 21 days, probably you would be able to achieve the same results as with 7 days of IV azacitidine. So hence, and there was another trial which was looking at the prolonged administration of azacitidine. So in this trial, they were giving 50 milligram per meter square for 10 days. Although this trial was not looking at the extended release, but this trial actually showed that if you are giving prolonged administration of AZA itself, it can increase the hematology, the transfusion independence and hematological response. So based on that, the next trial which was carried out was the extended dosing schedule of oral azacitidine. And here it was given for 14 days or 21 days. So this is how, the oral AZA instead of 7 days came to 14 and 21 days. And here, they looked at the response, and the responses were better what they saw with 7 days of schedule. So flexible dosing schedule allowed optimization of oral azacitidine. Again, looking at the pharmacokinetics and pharmacodynamics. So 300 milligram once daily or 200 milligram twice daily for 14 or 21 days were found to be useful, and it reduced the global DNA methylation in whole blood at day 15, 20, and 20 days. So if you are giving for 15 days, the action is lasting for approximately 21 days or so. So it is rapidly absorbed as soon as you give orally, and the oral bioavailability, as already said, is varies from 6.3 to 20%. And so this was the dose which was chosen for further trials. And this is the bioavailability which we are looking at: subcutaneous 89%, orally it is 11% or so. So obviously this trial, which is Quasar and AZA MDS 003, Dr. Austin in the previous presentation did discuss about this trial. And so I would just touch on that. In this trial, even though the patients achieve a transfusion independence, but there were higher risk of deaths in the oral azacitidine arm, probably because of neutropenia. And that's why this drug was not approved to be used as in patients with high in MDS patients. So there were more early deaths. However, as if you have listened to the previous talk of Dr. Austin, he did discuss that even MDS is a syndrome. So even though you are trying to classify the patient into low risk versus high risk, but there are many patients who are otherwise classified as low risk, but they are high risk category. And similarly, you have patients who are in high risk group, but they behave like a low risk. So even in this trial, there were a particularly unfavorable subgroup of IPSS patient where and almost 28% of these patients had high risk or very high risk, and they did better with this. And then the role of oral azacitidine came into as a maintenance therapy in patients of acute myeloid leukemia who went into complete remission. And here the drug oral AZA is approved for these patients. And this is the follow-up of this, which is published in Blood just recently. And even patients who are MRD positive are becoming MRD negative. Now, a little bit about the oral decitabine. As you know, with oral AZA, you have an oral decitabine also. And this is combined with the sidazuridine, which is a compound which actually inactivates the enzyme which is metabolizing the decitabine. And this actually is found to be very useful. I don't know why this is not popular. Instead of oral as a oral Decita with sidazurudine is better, because the pharmacokinetics and pharmacodynamics is almost the same. So you can use the same dose of IV decitabine as oral. And so this is looking at the oral bioavailability of the truths. You can see the decitabine has almost the same bioavailability. So two trials which Dr. Austin also showed, the ASTX727. So this is oral decitabine is approved for patients with to be used in MDS with these two trials. Whereas oral azacitidine is approved as a maintenance treatment for AML after induction chemotherapy for patients who are unfit for allogenic transplants. So what is going to happen, in future? So this was the potential. This talk is about the potential use. So obviously we need to look at the future. So the current FDA approved indications are narrow. The efficacy needs to be shown in clinical trial, as I already said. So obviously we need to identify the predictive biomarkers for clinical benefit, post-transplant maintenance therapy, and potential combination therapies, such as venetoclax, IDH, or FLT3 inhibitors. So what these are the some of the trials which are going on with oral as I said, venetoclax, magrolimab, or with other agents, and with oral decitabine, the other agents. So there are a host of clinical trials which are in the pipeline, and hopefully we will get the results. When I tried to search the clinical trial with oral in high risk MDS, I got 23 studies which are still in pipeline. I'm not sure whether you are able to see this or not, but I can just, you can take these words. So the potential role of oral is actually when you use in combination with venetoclax or with FLT3 inhibitors, or even you can use combination of oral venetoclax and FLT3 inhibitors, or with IDH inhibitors. That means oral plus X plus Y, whatever compounds based on the mutation testing, based on the cytogenetics which is available. So probably this needs to be tested in the clinical trials before you start making a routine use of these patients. So finally, the HMA forms the backbone of treatment of high-risk MDS or AML. However, they are to be given indefinitely until the patient develop resistance or progression. The oral formulation of AZA and Decita are welcome addition as patient-friendly approach. However, they need to be tested in clinical trials, either alone or in combination, before their widespread use in practice. With that, I thank you very much for your kind attention and happy to take questions.